So here is an explanation for seizures and epilepsy. So let's start by defining seizures. So a seizure is a paroxysmal event. Paroxysmal means it happens suddenly and it is due to abnormal, excessive, and hypersynchronous discharges from an aggregate of central nervous system neurons. So an aggregate of central nervous system neurons will have an excessive discharges of signals that will go on to cause symptoms in different parts of the body. And those symptoms are different according to the type of seizure, and we will explain those a little bit later in this video. Seizure is considered a symptom in comparison with epilepsy, which is a disease, and seizure mostly lasts less than 3 minutes in duration. Epilepsy, on the other hand, is a disease, as we mentioned, and it is defined by any of the following conditions. So we diagnose epilepsy if we have 2 or more recurrent seizures 24 hours apart and they are unprovoked, meaning that we need 2 seizures and the duration between them should be 24 hours or more and they should be unprovoked. Unprovoked means that the seizures occurs without a known or a fixable cause. The second condition at which we diagnose epilepsy is that we have 1 unprovoked or reflex seizure and a high probability for further seizures. And the third condition is the diagnosis of an epilepsy syndrome. So any of those conditions, if achieved, then we can diagnose epilepsy. Now let's talk about the causes of seizures and epilepsy. So they are caused by primary central nervous system disorders like genetic causes, cerebral dysgenesis, and structural causes like head trauma, and vascular causes like strokes and vascular malformations, and brain tumors, and CNS infections like encephalitis, meningitis, and HIV encephalopathy. And in a lot of times, we can't identify the cause, so we classify them as unknown causes. Seizures and epilepsy also caused by systemic causes like hypoglycemia, hyponatremia, hyperosmolar states, hypocalcemia, uremia, hepatic encephalopathy, porphyria, drug toxicity, drug withdrawal, and global cerebral ischemia in cardiac arrest, and some other systemic conditions, hypertensive encephalopathy, eclampsia, and hyperthermia. And most of the systemic causes are easy to fix, so that is why we search for them first when we search for the cause of seizures. So we search for the hypoglycemia, electrolyte disturbances, and the other systemic causes first. Then we think of the central nervous system causes like the CNS infections and the other CNS causes. Now let's talk about the pathophysiology of seizures. So any of the previously mentioned causes can affect the neurotransmitters in the brain and lead to seizure. And we have different neurotransmitters in the brain, but they are mainly classified into inhibitory and excitatory. The gamma aminobutyric acid is the main inhibitory neurotransmitter in the brain, which works on the GABA receptors, and the glutamate and aspartate are the excitatory ones working on the NMDA receptors. When they bind to the receptor, they open the sodium channels in the excitatory receptors. So normally, the excitatory and inhibitory neurotransmitters are balanced. But if the balance is disrupted, seizure occurs. So most types of seizures occur when there is either increase in the glutamate and aspartate, meaning there is increased excitatory neurotransmitters, or when there is decrease in GABA, which means there is decrease in the inhibitory neurotransmitters. Or if we have sodium channels dysfunction, because remember, the excitatory neurotransmitters work on the sodium channels. So if the sodium channels have dysfunction, this will lead to increased excitation and lead to seizures. That may occur when there is any cause of seizure is present. Increased excitation or decreased inhibition of the CNS lead to synchronous discharge of progressively larger groups of neurons, leading to a seizure. And to stop the seizure, we need to either decrease the CNS excitation by antagonizing the glutamate aspartate, or increase the CNS inhibition by enhancing GABA, or closing the sodium channels. So we either decrease excitation, or we increase inhibition, or we close the sodium channels. And those actions are done by anti-epileptic drugs. Absence seizures have a little different of a pathophysiology, because absence seizures are characterized by abnormal activation of T-type calcium channels in the thalamic relay neurons. Absence seizures pathophysiology is also related to increased excitation and decreased inhibition, but it's also related to the T-type calcium channels. The T-type calcium channels, when activated, they cut off the relay neurons and get the body to sleep, and that happens during the night only. But some kids with absence seizures, their T-type calcium channels get activated during the day also, which lead to short periods of unresponsiveness that happen during the day. So the treatment of these types of seizures is by blocking the T-type calcium channels, or the previous methods of treatment can be also applied, like decreasing excitation or increasing inhibition. Now let's talk about the classification of seizure types, and the most recent classification of seizure types as of 2023 is the International League Against Epilepsy classification of 2017. Credit goes to Dr. Robert Fisher and all the doctors involved in this classification, and I highly recommend you reading the papers of this classification. I will link them in the description of this video. So seizures are classified into focal onset, generalized onset, and unknown onset. Focal onset means that the onset of the neuronal discharges is limited to one hemisphere. So focal is one hemisphere. But in generalized onset seizures, the neuronal discharges is starting in both of the hemispheres. So both hemispheres in generalized onset. And if the onset is unknown, then it could be either generalized or focal. Now, focal onset seizures are furtherly classified into aware and impaired awareness. And awareness means awareness to people and environment. You investigate for awareness by asking the patient of what happened during the seizure, and if they give you a clear answer, then this means the patient awareness is retained, and if they give you a vague answer, then it is impaired awareness. Focal onset seizures are also classified into motor onset and non-motor onset. Motor means that there is some type of movements that happen during the seizure. Non-motor onset means everything other than the motor onset. For example, changes in sensation, changes in thinking, and changes in experiences. And with focal onset seizures, there is always the possibility of them turning from focal to bilateral, tonic, clonic. Regarding the generalized onset seizures, they are classified into motor and non-motor. The motor generalized onset seizures is furtherly classified into tonic, clonic, and other motor, and the non-motor is being the absence seizures. And we have the unknown onset seizures, which also classified into motor, which is tonic, clonic, and some other motor, or it could be non-motor, like behavioral arrest. And we have seizures that are unclassified. Now let's talk about each type of seizure in more details. And let's start with the focal onset seizures. So the previous term for them is the partial seizures, but this term is not used anymore. We use the focal onset seizures now. And this type of seizure starts in a network of cells on one hemisphere, as I mentioned, and it is usually the temporal lobe in 80% of the cases, or it could be the medial frontal lobe, but also it can originate anywhere. The focal onset seizures could manifest as motor symptoms such as twitching or jerking movements, which are called clonic, or stiffening movements, which are called tonic. They could be also manifest as automatic movements such as licking lips, rubbing hands, walking, and running. Or they could manifest as non-motor symptoms such as changes in sensation, emotions, thinking, or experiences. The focal seizures generally persist for less than 3 minutes, and bilateral propagation into tonic-clonic seizures may occur. Bilateral propagation is when the signals would propagate from one hemisphere to involve both of the hemispheres. We also mentioned that the focal seizures are classified according to awareness during the seizure into intact awareness, and the previous term for that is simple partial seizures, but the new name is the focal onset seizures with intact awareness or focal aware seizures. And they are also classified into impaired awareness, and the previous term for that is complex partial seizures, but those terms are not used anymore. The new term is the focal onset seizures with impaired awareness or focal impaired awareness seizures. And the propagation to bilateral tonic-clonic seizures, the previous term for that was secondary generalization, but the new term is focal to bilateral tonic-clonic. So there is a video playlist of real examples of seizures that you can watch, and it is linked in the description of this video. So to understand seizures better, you have to watch it so you remember them well. Now let's talk about the generalized onset seizures. So awareness is impaired in most types of generalized onset seizures, so it is not used in the classification, and the generalized onset seizures are classified into motor. Example for the motor is the tonic-clonic seizures, and the non-motor, which are the absence seizures. So let's talk about the tonic-clonic seizures. So those types of seizures are previously called the grand mal epilepsy, but the new term for them is the tonic-clonic seizures. They include the tonic phase, the clonic phase, and the post-ictal phase. So they start with the tonic phase. The tonic phase is a stiffening and contraction of limb muscles for around 30 seconds, producing flexion first and then extension. So in the beginning of the tonic-clonic seizures, there will be stiffening and contraction, producing flexion first, but then extension. And that lasts for about 30 seconds. The tonic phase also includes the contraction of back and neck and respiratory muscles, producing forced expiration, which will produce a cry or moan noise. And this will also lead to cyanosis. So because of the hard contractions that happen, even the respiratory muscle would contract, producing forced expiration in a cry or moan sound. There will be also cyanosis because the breathing is impaired during the contraction of the respiratory muscles. Cyanosis occurs because breathing is impaired during the contraction of the respiratory muscles. In the tonic phase, there is also contraction of the masticatory muscles, which may cause tongue trauma, and during this phase, the patient fall to the ground and may get injured. Now, after the tonic phase comes the clonic phase. The clonic phase is characterized by jerking movements, which is alternation of muscle contraction and relaxation. So we have contraction, relaxation, contraction, relaxation. So it would produce jerking like that. And this phase would persist for another 30 to 60 seconds or longer. Respiration returns in this phase and cyanosis clears, and salivation out of the mouth may occur, and urinary sphincter relaxation or detrusor muscle contraction may occur, leading to incontinence. After that comes the post-ictal phase. So the post-ictal phase is characterized by confusion and headache that will take 10 to 30 minutes or longer. Now let's talk about the generalized onset non-motor seizures, which are the absence seizures. So the non-motor generalized onset seizures, which are the absence seizures, the previous term for them is the petit mal, and they are genetically transmitted. They present through the childhood period, and they rarely persist after. The absence seizures are characterized by brief loss of consciousness for 5 to 10 seconds without loss of postural tone. During the absence seizures, there might be some motor manifestations such as eye blinking and head turning, but full orientation is present immediately after seizure cessation. So in the absence seizures, the child would become unresponsive for 5 to 10 seconds, and their postural tone is present, so they would be in their previous position, but they would be unresponsive for that period. And there might be some eye blinking or head turning, and frequency of absence seizures is high. There might be several hundreds a day, and they are mostly induced by hyperventilation, and characteristic electroencephalogram pattern is the 3 Hz spike wave activity. So we mentioned that the generalized onset seizures are classified into motor and non-motor, and we mentioned that the motor include the tonic-clonic seizures. Now also in the motor generalized onset seizures we have other types like the tonic seizures, which include only stiffening and contractions, and we have the clonic seizures, which include only the jerking phase, so there will be only jerking in those seizures. And we also have the myoclonic seizures, which are characterized by sudden and brief shock-like contractions that are localized to few muscles or 1 or 2 extremities. And we also have the atonic seizures, which are characterized by the loss of postural tone. Now let's talk about the status epilepticus. So when the seizure duration is longer than 5 minutes, we consider it to be status epilepticus, and this need emergency treatment, else it may lead to irreversible brain damage and even death. Brain damage starts after the 20 minutes mark, so we need to take action before that and stop the seizure. And the incidence of the status epilepticus is around 50 per 100,000 seizures. Now let's talk about the diagnosis of seizures. So we start with history and physical examination, and we send the patient for serological tests like complete blood count, looking for infection and electrolyte disturbances, and glucose and liver function tests and kidney function tests. We also send the patient for lumbar puncture if meningitis is suspected, and we also may do electroencephalogram. CT scans or MRI scans may be needed, and PET or SPECT scans may also be needed. The treatment of seizures is with anti-epileptic drugs. Surgery might be an option if anti-epileptics fail, and we also have other options like ketogenic diet and vagal nerve stimulation. Regarding the anti-epileptic drugs, they are classified according to their mechanism of action into drugs that work on the excitatory neurotransmitters, or drugs that work on the GABA, or drugs that work on the T-type calcium channels, and drugs that work on the sodium channels. And anti-epileptic drugs are also classified according to their therapeutic uses, but the basic classification for them is that we classify them into first generation and second generation. The first generation of the anti-epileptic drugs is also called the classic drugs or the old drugs. And the second generation are called the newer drugs. And all of these, the first generation and the second generation, are used. So the old drugs are also used for treatment of epilepsy. And for the first generation, we have the phenytoin, the carbamazepine, the valproic acid, the ethosuximide, the phenobarbital, and the benzodiazepines. And for the second generation, we have the vigabatrin, the lamotrigine, the topiramate, the levetiracetam, and the gabapentin, and the pregabalin, and the tiagabine. And this classification is important to memorize, so I highly recommend you memorize this classification, and in the next videos we will explain each of these drugs in separate videos. And with that, we reach the end of this video. Thank you guys for watching. Please support this work by liking this video and commenting your ideas and questions. And I highly recommend you to watch my playlist of real examples of seizures that will appear on your monitor right now. And this video is a part of the Central Nervous System Pharmacology Masterclass, and there's also more videos explaining different medications that work on the CNS that you can check out by clicking on my CNS Pharmacology Masterclass playlist.